Professor Sulfikar is there. Sulfi, you are, come. Yeah. You need to rush. Yeah, he's a very close person to Fazil Marickar, sir. Then I have another stakeholder for this transplantation, Dr. Ganapati also, in fact, I have invited. But Dr. Ganapati, are you in the crowd? Please come. Yeah. Will you please come? Please come. Because there are three, this oration is very important, for three respects. Number one, the champion medical legend for whom, as a tribute, we are conducting this oration. The second, in fact, is a topic, The topic, the transplantation, when we talk about liver transplantation, it's a 65-year-old program elsewhere in the world. But still, though we have started and done well now, it's ailing right now. And then it's our duty to take it up. And the third is the orator, about whom I'll be just telling you. After Dr. Sulfi has actually given his tribute to Fazil Marickar, sir. Dr. Raj, are you online? Dr. Raj? Dr. Raj? But he'll be joining from Cambridge. Yeah. So I think we'll start then. Yeah.
With your permission. Okay. Good afternoon, my teachers and my brothers and sisters. It's both an honor and a privilege to be called upon to introduce an extraordinary human being who is no longer with us, Dr. Y.M. Fazil Marickar. He left us in 2022 and his death anniversary is exactly 2 weeks from now, that is on 22nd of March this year. And actually I came with no intention to mourn his death, but to celebrate his life along with you. And because he was exactly was doing that, and even when facing a very cruel medical adversary, in fact. And Fazil sir did his MBBS in 1971 and his MS General Surgery in 1976 and got a PhD in 1991, which was the first of its kind because the first time in Kerala a medical doctor got a PhD. He was awarded the prestigious FAMS in the 1919 and he retired as HOD of our own medical college surgical department and later on went on to become the principal of Mount Zion Hospital and the vice chancellor also. And his passion basically and the subject of research was urolithiasis, which naturally brought him many accolades, both national and international. But what sets him apart from us ordinary mortals are his visionary approach to clinical research and his missionary zeal or approach to surgical training and of course profound humanity and humility. A true clinical scientist he was. I think I would say, just like our T.S. Eliot said, the quartets of his personality, I suppose, would be one, an excellent surgical skill, especially with the immense patience. Second is a genuine research and knowing the potential of computers and other things in the early days. Suppose he was here, now he would have been basically an expert on AI. 3 is a near perfect work culture, time management and punctuality. 4th, he was a good man. You know, we all know that there are very few people around these places, good people, including us, me. On a lighter vein, all of us remember his style of dressing. He used to, has his full sleeves rolled up like our old 60s film stars in Tamil and Malayalam and Hindi. And, but of course, Sir was also a handsome person like our heroes. And he was a valiant warrior facing the tragic malady which eventually overcame him. His response to that was a cheerful and self-deprecating courage. His life and legacy lives on. I would conclude quoting a poem by Dr. John Donne, Death be not proud. One short sleep past, we wake eternally. That's what we will do. And death shall be no more, and death thou shalt die. I think that epitomizes the life and death and the legacy of Dr. Fazil Marickar. Thank you.
Thank you very much, Professor Sulfi. Raj, are you with us? Are you with us?
Can you hear me?
Yeah,
I can see you.
Oh, yeah, sure, sure. Very good, very good. So I think good morning to you. It should be good morning there, no? Yeah, we had our lunch here. Yeah, we had our lunch. So it's a post-lunch session here. So thank you for being with us. And in fact, the short introduction of the tribute to Professor Fazil Marickar was done. In fact, probably I don't know whether you have heard about that, Then I'll be having a short introduction about you. So that's what I'm going to do. So Dr. Rajkumar Prasidam is our own alumni. He completed his MBBS in 1987 from here, and after his MS, he moved to UK. And then he is the lead transplant of one of the biggest transplant program in the world, and that is the Addenbrooke Hospital, Cambridge. There he had actually trained many liver transplant surgeons, including most of the famous liver transplant surgeons in Kerala and South India. So, he has quite a lot of academic accolades and professional accolades, which I am not actually taking you through. But then he is the consultant right now to transplant surgeon to Addenbrooke, as I have mentioned, and he has got many professorial affiliations and professorships to many universities in the world, including Manipal University. And then he was the chair of the FRC's examination, and he is the regional director of Royal College of Surgeons. But I can tell you that beyond all these things, he's a close friend of mine. When I say he's a close friend of mine, I'm very sure that he is a very close friend of many of you. Many of you in the audience, He is a very humble person. He is very caring and sharing, and that is what makes him great. And then, in fact, what is needed for a lead for a cadaver transplant program. So I think, Raj, what we need, why I wanted to come here is that, what we need is, in fact, icons like you. Icons like you. We miss icons like you. Sincerely, I feel that the problem of transplantation, cadaver transplantation here in Kerala, though we have started well, is the lack of icons like you. So we want you to be the icon. So I think with these few words, I would like you to start with the oration. Because I know that I have brought the stakeholders here. I know that this oration has no questions or discussions. And however, this will be the initial point for the discussions which I am going to arrange later. So I think right now there is no discussion. We'll just listen to the words of wisdom of this iconic figure to whom the whole world, in fact, is listening to. And then we will conduct debates and discussions about our problems later. So, Josh, now for you. There is customarily, there is actually a medallion. In fact, we'll keep the medallion here, and then probably, we will send to you. We will send to you. Okay?
Thank you
very much.
Thank you. Can you hear me now?
Yeah, we can hear you very well. Yeah, very well.
I will share my presentation now.
Yeah, sure. Please. Stop.
So once again, thank you for that very kind introduction. So distinguished chairpersons, guests, colleagues and friends. Firstly, I would like to thank all the organizers of the Trivandrum Medical College Alumni Association, particularly you, sir, for inviting me to give this inaugural Professor Fazil Marickar oration. Before I get into the matter, I'd like to take a moment to remember Fazil sir. Fazil sir was my teacher in the late 80s when I was doing my MS General Surgery in Trivandrum. He was uniquely different to every other faculty member in the surgical department at that time. He was extremely academic in the true sense of the word. These days, we use the word academic for anyone who teaches in a medical college. But Fazil sir was an academic in the true sense of the word academic. He carried out original basic sciences research, particularly in the field of urolithiasis. He published and encouraged his trainees to do the same. He was a fantastic surgeon technically, never boasted about his surgical prowess, but I can testify firsthand his surgical skills. I also remember his support for postgraduate trainees when he was on duty. He gave hands-on training to his postgraduate trainees and supported them fully in difficult circumstances. He was indeed a true academic surgeon, trainer, and a gentleman. His passing is indeed a great loss to the Trivandrum Medical College alumni. I am therefore honored and privileged to give this Professor Y.M. Fazil Marickar oration today. Vinay Kumar sir has been lobbying the establishment of a sustainable cadaveric liver transplant program in Kerala for the last 25 years. And I've had many a long discussion with him on that matter. So it was no great surprise that he chose this particular topic for me to discuss with you today. So the question is, cadaveric transplantation, what ails Kerala? So what is the problem? In the 11-year period between 2012 and 2023, we had 339 cadaveric donors in Kerala. With a population of 35 million, that gives us a cadaveric donation rate of 0.36 PMP per million population. So how do we compare with the rest of the world? Spain is and has always been the cadaveric donation capital of the world. With a population of 49 million, which is a little more than Kerala, the cadaveric donation rate for Spain is a whopping 47 per million population. The reasons for that, I'm not going to go into detail today. In the UK, with double the population of Kerala, has a cadaveric donation rate of 21 per million population. Some 15 years ago, it was languishing at around 13 per million population before the government intervention led to increase in the donation rate to the current 21 per million population. But let's take a closer look at home. In the same year, 2022, Telangana, Tamil Nadu, Karnataka,
Excuse me, Raj, you are not sharing your presentation. From your end, can you share your presentation?
It says I'm sharing it.
But then, can we run from here?
Let me stop share and start again.
Will you please start again? Yeah, now we can see it. No, I think you need to make it full screen then, but not now.
Sir, can you select entire screen when you're sharing?
Okay.
Sir, are you able to share the screen now?
Yeah.
Yeah, so
This is the entire screen.
okay, let me check.
Please hold on for a minute.
Yeah.
Yeah. Now it's okay. Continue, please.
I'll continue from my current slide.
Yeah.
Okay.
Sure. Thank you.
So in this slide, we got the data from 2022. And in India, Telangana, Tamil Nadu, Karnataka, Gujarat, and Maharashtra had between 100 and 200 cadaveric donors. These are not big numbers by any standard, particularly with the bigger population base. But how did we do in Kerala? We managed to scramble just 9 cadaveric donors in 2022. But more worryingly, there was a sharp drop from the heady heights of 76 donors in 2015. So the question is, why is it that we as Malayalis do not support cadaveric transplantation, but prefer to put healthy people's lives at risk by preferentially carrying out living donor transplantation? Do we as professionals realize the risks involved in this procedure? Does the population at large understand the risks? For example, the risk of death following a live donor liver donation operation is conservatively estimated at 1 in 200. Do we not realize that our life-saving transplant numbers will exponentially shoot up even with a small increase in the number of cadaveric donations? Although the issue at stake here is a complex one with many confounding variables, let me get straight to the point and try and give you a short, sharp answer to the question, what ails Kerala? The answer in my mind is trust, or rather lack of it. Firstly, let me put my cards on the table. Though I qualified, trained and worked in Kerala prior to going to the UK, I've been working in the UK for the last 32 years, and therefore, my arguments today are going to be rather biased from the perspective of working in a country with socialized medicine and a totally different socio-cultural background. I don't think anyone here will really understand the concept of social medical care. Suffice to say that in a socialist system of medicine, it doesn't matter whether you're the King of England or a homeless person on the streets of London. Whether you need lipoma excision or a liver transplant operation, you get it free of cost in the NHS, totally. You cannot jump a queue just because you have money. So I apologize in advance if I sometimes sound very critical. I believe that we in Kerala have lost trust in our systems and processes, and that those systems and processes that should ideally deliver safe, transparent medical services without corruption. Now, I say this because India tops the world in terms of where people are most willing to donate organs. We Indians rank higher than Spain and the US, which have the highest donation rate in the world. Despite this willingness, the donation rate in India, and particularly in Kerala, is dismally low. I can only assume that we are truly an altruistic people but are denied the opportunity due to the lack of transparency and the corruption often seem to be associated with organ transplantation. So, what are the factors that lead to this perception by the public? The fact that majority of both transplantation and donation occurs in the private sector puts suspicion in the minds of the general public. Please do not get me wrong on this. The private sector in Kerala is amazing, with really good care being delivered at majority of the corporate hospitals. Living donor liver transplantation, for instance, requires a much higher level of surgical skill that is being delivered in spades in the private sector in Kerala. The latest techniques in living donor hepatectomy, such as robotic hepatectomy, are all available in Kerala. But it is a fact that the general public harbors suspicions about the care in the private sector. This is data from KNOS, which confirms that majority of the cadaveric transplant activity is in the private sector. It is the same for cadaveric donation. So, it seems that the private hospitals are producing the donors and doing the transplants as well. What is perhaps disappointing from this slide is that from producing some decent number of cadaveric donors between 2013 and 2016, we seem to have slipped to an all-time low in 2024. Now, some of these suspicions with the private sector are because transplantation is an expensive affair. It's very costly to assess patients for transplantation. The transplantation procedure itself is expensive, and post-operative care with expensive immunosuppression medications are lifelong. Now, are we clear about where the money goes? Does it go to intermediaries? Can we, with hand on heart, say that we have always followed the principles that are embedded in the Human Transplant Act of India? How transplants have how transparent have we been as medical professionals, particularly with respect to allocation of cadaveric organs, for instance? Have we been diligent about money changing hands between recipient and donor? This is expressly forbidden by law in India. Now, this is where the lack of socialized medicine in our country becomes a big problem. I feel that the trust is simply not there because the amount of money that is involved. Now, what about the role of media and social media in promoting cadaveric donation? It is the job of the media to bring issues to the attention of the public. Freedom of the press is crucial in a democracy. I'm sure the courts will rule on some of these issues which are currently up there. They will eventually solve it, I'm sure of it. But the fact that we as medical professionals fail to show due process and fail to demonstrate transparencies cannot be excused. When the public fail to understand the complexities in medical care, when they see opaqueness, particularly for services that they pay through their noses, is it any wonder that they turn against the medical professionals and hospitals and don't care much about an altruistic action like cadaveric donation? Please make no mistake, there are good news stories in the media on cadaveric donation and transplantation that leads to increase in cadaveric donation rates. I'm sure that these two movies put a drag on an already dwindling cadaveric donation rate. However, there have been other movies like Traffic, which was a feel-good thriller to compensate for the negativism that might have been brought on by these two movies. Now, again, please don't make any mistakes. Many more movies on organ trafficking have been made in Hollywood, that too as long back as the 1970s. Whenever such negative issues appear in the media, even in the Western world, it will bring the donation rate in the Western world just transiently. Within a few weeks, it'll pick up again. On the positive side, our Malayalam actors like Mohanlal and Navya Nair have become ambassadors for organ transplantation. Maybe the medical professionals are not utilizing them fully. Our socio-cultural infrastructure, in some ways, is much, much better than the Western society. When there is death or serious illness in the family, there is a lot of support from family and friends in India. Unfortunately, this can also lead to a lot of hesitancy and lack of decision-making at crucial times. If you have 5 relatives and friends, they will confuse the next of kin with 10 different opinions. The next of kin is often not allowed to make the decision to donate. I dare say that a very thriving living donor program can affect the establishment of a cadaveric program in a negative way. Why go to all the effort of identifying, managing and carrying out cadaveric transplantation and all the negative publicity that attracts in Kerala? Nobody cares if a relative or a close friend donates as a living donor. It's between the donor and the recipient, isn't it? But remember, there are thousands of people dying on the transplant waiting list who do not have the luxury of having a living donor. When talking about socio-cultural issues, a brief note on religion, organ transplant, and organ donation. The common thread that binds all religions in the world is that saving life overrides all objections. No religion is against organ donation. What holds us back are cultural reservations, ignorance of the process of organ donation, fear of mutilation, lack of emotional support at the time of tragedy, fear that the organs will be sold or used only by the rich, mistrust of hospitals and health professionals, and certain other myths that go along with it. Now, what is death? Okay. When someone is in an intensive care unit, the medical professionals are obviously trying to fix a medical problem in the patient. A lot of the time it is apparent that these patients are never ever going to get better. This is the this is the time for the medical professionals to make the call. Enough is enough. Futility of treatment, that's the word. Futility of treatment needs to be confirmed by the treating team and discussed with the relatives very frankly. Unfortunately, in countries without socialist medical care, many other factors, including costs, will come into the equation. Once futility of treatment is established and discussed with the family, physicians can test for brain death. Organ donation, though, should not be a consideration before futility of treatment is decided. Then again, how many of us really know the difference between all these terms I have mentioned here, brain death, persistent vegetative state, cardiac death? Is it then a surprise that the general public struggle to understand these concepts? Making the decision that continuation of life-sustaining treatment is of no overall benefit to the patient is the critical point in the care pathway. This decision needs to be wholly independent of the decision as to whether organ donation is appropriate in that patient or not, as the patient will typically be unconscious in an intensive care. The clinician responsible will need to consult with the patient's family and come to an appropriate view. In the UK, 2 senior doctors registered for at least 5 years, at least one of whom is a consultant, should verify that further active treatment is no longer of any benefit to the patient. The family will not be approached about organ donation unless and until the decision to withdraw life-sustaining treatment has been made and independently agreed and the family has accepted this. Once the futility of treatment has been decided, discussed with the family, brain stem deaths may be carried out. Typically, the patient is on a ventilator. He or she undergoes an apnea test which confirms that the patient cannot breathe without support. Then the cranial nerves are tested. For a diagnosis of brain death, the person must be unconscious and fail to respond to outside stimulation. The person's heartbeat and breathing can only be maintained using a ventilator. There must be clear evidence that serious brain damage has occurred and it cannot be cured. Now, certain other conditions need to be ruled out before you can start brainstem death tests. An overdose of illegal drugs, tranquilizers, poisons, other chemicals, an abnormally low body temperature, severe underactivity of the thyroid gland, and other electrolyte imbalances. Now, this is totally different to persistent vegetative states. In persistent vegetative states, the patient may or may not be on a ventilator, but the treatment has been deemed futile in this case as well. Such patients can live for days, weeks, months, or years. Now, please do note that the brain stem death test will not be positive in these patients. These patients are not donors unless their heart stops. Now, this again are some of the other differences between brain stem death and persistent vegetative states. Now, not going to go through every single test that you need to do in brainstem death confirmation. In the UK, 2 doctors have to carry out these tests at an interval to confirm brain death. We in the UK do not need more than 2 doctors, nor do we need any fancy investigations or videography. No additional testing like CT scan, CT angiography, etc. are required unless there are other issues. Only in exceptional circumstances are they needed. We do not videograph the actual test. Interestingly, the UK law says that the body of anyone dying in a National Health Service hospital belongs to the Minister of Health until release. That would be a very amusing situation in the Kerala context, I believe. Now, one other thing to say here is that the test cannot be initiated or carried out by anyone associated with the transplant unit or a transplant unit. Now, what is donation after cardiac death? in the Western world, this is on the rise. In fact, in the UK, some 40 to 50% of the donors are donation after cardiac death. These patients are not brain dead. When you do the brainstem death test, you find that they are negative. These potential donors are still on a ventilator, but going back to my first point, the treatment is deemed futile. After appropriate consent from the family, the potential donor is disconnected from the ventilator. Should cardiac death occur within a reasonable period of time, that is the heart stopping, then organ donation will proceed. Should cardiac death not occur within a reasonable period of time, the patient is returned back to the ward for end of care life support, which is just tender loving care only. So, are there any solutions? I personally don't think we should go for a quick fix. In fact, I don't think there are any quick fixes which are sustainable in the long term. We need a solid foundation to embed a sustainable cadaveric transplant program in Kerala, which will benefit much of the ordinary people, whether they are rich or poor. So my usual single word response to this rather complex problem with many confounding variables is education. So, there are some long-term solutions which I would like to suggest. Can we please encourage transplantation in the government sector? I know this is not the priority for the health minister in Kerala. There are many other things which deserve our attention. But it's very important that we encourage transplantation in the government sector. We should
transplant.
We should encourage cadaveric donation through education, and I would suggest that education on this matter starts from school onwards. We need to have transparency with respect to all aspects of transplantation, particularly with outcomes from transplantation. Do we really know how long people live after an organ transplant, a liver transplant, for instance? What are the costs? Where does the money go? Organ allocation policies and the ethics associated with it. We need much more transparency on all these matters. I would like to beseech the media that they run balanced articles on this subject and not get too carried away by the scandals. I understand that the scandals are what sells newspapers and get the likes on social media, but I feel that good news stories should also be given prominence. Otherwise, we will be shooting ourselves in the foot. Now, I started by saying that my perspectives are based, or biased rather, by my last 32 years of working in the UK. What works in the UK may not work in India. I just want to illustrate this point with this last slide, just to see how thought processes are there in the UK as opposed to what we think about cadaveric donation in Kerala. And that's the big difference in the socio-cultural and socialist medicine that we have in the UK versus in Kerala. Have a look at this slide. Don't worry about all these numbers here. This shows the demographics of cadaveric UK donors for the financial year 2022-2023. Don't worry about numbers, it's a busy slide. Just look at one statistics where I put the arrow. Despite the rather large representation of Asians in Britain, they only contribute to 4% of the cadaveric donors. We seem to behave the same wherever we go, it seems. But the NHS is set up in such a way that all are considered equal, rich or poor, Asian or Caucasian. If you look at the waiting times for somebody, an Asian person, for instance, for a liver transplant, it is the lowest. They wait significantly lower than the white Caucasian population despite not donating. This is because the country values equality, equity, diversity and inclusivity. It is a socialist medical system. Now we can't bring suddenly socialist medical system into another country. But I just want you to consider all the things I said from this particular background, and what is applicable in the UK may not always be applicable in the US. So you need to think very carefully. So once again, my thanks to all the organizers of this wonderful, wonderful event and for asking me to give the Professor Fazil Marickar Oration. Thank you. Thank you.
Thank you very much, Raj. It's wonderful. Thank you very much for the words of wisdom. And I think you have given many ideas for us to think about and discuss. And we badly need your help when we try to retrieve the system. So I think with these words, I would like to close this session, oration, and I thank all the chairpersons for being with us. And then I promise that Lumini will be conducting a series of discussions, Then we would like to hear about the problems from all the angles, 360 assessment, and then we'll have to find a way forward. So thank you, Dr. Raj, and a huge round of applause for Dr. Raj. Be with us as an icon for this great movement. Thank you very much.
Thank you. Thank you.